Heart failure. Chronic Jeffrey A. Shee, MD Youssef Rabban, MD Basics Description. Heart failure, HF, is the condition resulting from inability of the heart to fill and/or pump blood sufficiently to meet tissue metabolic needs. Alternatively, HF may occur when adequate cardiac output can be achieved only at the expense of elevated filling pressures. It is the principal complication of heart disease. For acute HF, see heart failure, acutely decompensated. HF is the preferred term over congestive HF because patients are not always congested, fluid overloaded. HF may involve the left heart, the right heart, or be biventricular. The New York Heart Association, NYHA, classification is a subjective grading scale used for classifying a patient's functional status. NYHA-I, asymptomatic, NYHA-2, symptomatic with moderate exertion, NYHA-3, symptomatic with mild exertion and may limit activities of daily living, NYHA-4, symptomatic at rest. The American Heart Association, AHA, and American College of Cardiology, ACC, stages is a system to delineate the progression of HF. Stage A, patients at risk for HF, no structural disease. Stage B, structural disease, no HF symptoms. Stage C, structural disease, HF symptoms. Stage D, end-stage HF disease. Epidemiology. HF accounts for close to 1 million hospitalizations a year with 25% readmitted within 30 days. The annual direct and indirect cost of HF in the United States is $34.4 billion. Incidence in the United States, 550,000 new cases diagnosed annually with greater than 250,000 deaths per year. Prevalence: an estimated 23 million individuals have HF worldwide. 6.5 million people in the United States have HF, 1% in those age 50 years, increasing to 10% of those age greater than 80 years. Primarily a disease of the elderly, 75% of hospital admissions for HF are for persons greater than 65 years of age. Etiology and pathophysiology. Two physiologic components explain most of the clinical findings of HF and result in classifications in four general categories: HF with reduced ejection fraction, HFrEF, or systolic HF, an inotropic abnormality, often due to myocardial infarction, MI, or dilated cardiomyopathy, CM, resulting in diminished systolic emptying, ejection fraction F less than or equal to 40%. HF with preserved ejection fraction, HFpEF, or diastolic HF, a compliance abnormality, often due to hypertensive CM, in which the ventricular relaxation is impaired, F greater than or equal to 50%. Borderline HFpEF, F41-49% mild systolic dysfunction but clinically behaves like HFpEF. Improved HFpEF, F40% previously HFrEF but with improvement in systolic function. Patients with systolic dysfunction may also have diastolic dysfunction. Most common etiologies: coronary artery disease, CAD/MI and hypertension, HTN, myocarditis and CM, alcoholic, viral, long-standing HTN, drugs, e.g., chemotherapeutic agents, muscular dystrophy, infiltrative, e.g., amyloidosis, sarcoidosis, postpartum state, infectious, e.g., Chagas disease, HIV, hypertrophic CM, HCM, inherited familial dilated CM, left ventricular, LV, non-compaction valvular and vascular abnormalities, any valvular stenosis or regurgitation, rheumatic heart, renal artery. Stenosis, usually bilateral, may cause recurrent flash pulmonary edema, especially in setting of severe chronic HTN. Chronic lung disease and pulmonary HTN, COR pulmonal, iatrogenic volume overload, requires extreme overload in patients with normal hearts and kidneys, arrhythmias, atrial fibrillation and other tachyarrhythmias, high-grade heart block, frequent PVCs, miscellaneous, high output states, hyperthyroidism, anemia, cardiac depressants, beta blocker overdose, stress-induced idiopathic, 20–50% of idiopathic dilated cardiomyopathies are familial. HF is progressive, manifested by the remodeling, altered heart geometry, process. Genetics. Multiple genetic abnormalities responsible for a variety of phenotypes have been identified. HCM, arrhythmogenic right ventricular RV dysplasia, LV noncompaction, dilated CM. Consider genetic screening for first-degree relatives of HCM and arrhythmogenic RV dysplasia. Risk factors for development of HF, CAD/MI, HTN. 80% of cases of HF in the United States caused by either CAD or HTN, valvular heart disease, diabetes mellitus, cardiotoxic medications, e.g., anthracyclines, tyrosine kinase inhibitors, tumor necrosis factor alpha inhibitors, obesity, older age. General prevention. Control HTN and other risk factors. Thiazide diuretics and angiotensin-converting enzyme inhibitors, ACEI, are superior to other agents in preventing development of HF. Commonly associated conditions. Sudden cardiac death and progressive pump failure are the leading causes of death. Most patients have greater than 5 comorbid medical conditions and take greater than 5 medications. Diagnosis. History. Dyspnea on exertion, cardinal sign of left-sided HF. Deteriorating exercise capacity, easy fatigued, general weakness. Nocturnal nonproductive cough, orthopnea, and paroxysmal nocturnal dyspnea, sometimes frothy or pink sputum. Wheezing, especially nocturnal, in absence of history of asthma or infection, cardiac asthma, Cheney-Stokes respirations. Anorexia and or fullness or dull pain in right upper quadrant, hepatic congestion. Nausea and poor appetite may indicate advanced HF. Physical exam. Increased filling pressures, rales and sometimes wheezing, peripheral edema, S3 gallop, hepatomegaly, jugular venous distension, hepatojugular reflux, ascites. Remodeling, enlarged or displaced point of maximal impulse. Poor cardiac output, hypotension, pulsus alternans, tachycardia, narrow pulse pressure, cool extremities, cyanosis. Differential diagnosis. Simple dependent edema, pulmonary embolism, exertional asthma, cardiac ischemia, asthma/chronic obstructive pulmonary disease, constrictive pericarditis, nephrotic syndrome, cirrhosis, venous occlusive disease with subsequent peripheral edema, high output states, anemia, sepsis, hyperthyroidism, lymphedemia. Tamponade. Diagnostic tests and interpretation. Diagnosis should be primarily clinical, with laboratory data as adjunctive and indicative of complications. Initial tests, lab, imaging, beta-type natriuretic peptide, BNP, and N-terminal proBNP, NT-BNP, are helpful in the acute setting to differentiate the cause of dyspnea. BNP 100 essentially rules out HF. A BNP level in those with risk factors for developing HF or with structural heart disease but no symptoms of HF can help predict the development of symptomatic HF. 1a. Other, non-HF conditions, such as pulmonary embolism, renal failure, and acute coronary syndromes, may cause elevated BNP. Of note, sacubitril/valsartan, Entresto, an angiotensin receptor blocker and neprilysin inhibitor can raise BNP levels but has less impact on NT-proBNP levels. Obesity may lower BNP levels. The use of BNP-guided therapy in chronic HF and acutely decompensated HF is not well established, although a pre-discharge BNP can predict risk of readmission and survival. 1a. Lab findings include respiratory alkalosis, mild azotemia, decreased erythrocyte sedimentation rate, proteinuria, usually 1g/day, elevated creatinine, cardiorenal syndrome, dilutional hyponatremia, poor prognosis, hyperuricemia, and hyperbilirubinemia. Chest X-ray, changes lag clinical symptoms by up to 6 hours. Increased heart size, vascular redistribution, cephalization, with butterfly pattern of pulmonary edema, interstitial and alveolar edema, curly B lines, and pleural effusions. Findings of pulmonary edema may be absent in long-standing HF diagnostic procedures / other determination of left ventricular ejection fraction, LVEF, is critical to proper diagnosis and management. Echocardiogram is the most useful test to determine LVEF, RV function, diastolic dysfunction, ventricular size, wall thickness, and valvular abnormalities. May be repeated if change suspected in underlying cardiac status. Nuclear imaging to estimate ventricular sizes, assess for ischemia or infarction. ATTR wild-type amyloidosis, and systolic function. Cardiac MRI can be considered in select circumstances: suspicion of cardiac sarcoidosis, arrhythmogenic RVCM, acute myocarditis, amyloidosis, and hemochromatosis. Cardiac catheterization is important for excluding CAD as an etiology in the setting of risk. Factors: endomyocardial biopsy should not be performed routinely, only in special circumstances, e.g., suspected giant cell myocarditis, that may change therapy. Test interpretation: cardiac pathology depends on underlying etiology. Treatment: general measures correct and treat risk factors for HF. The treatment of chronic HF is focused on improving hemodynamics, relieving symptoms, and blocking the neurohormonal response to improve survival. Medication: diuretics, for fluid overload, and nitrates, especially for hypertensive patients, are used initially in acute HF management. The addition of ACEI and aldosterone antagonists, especially for HFrEF, can be added at any time. Once acute HF is stabilized, a beta blocker should be started. Avoid nonsteroidal anti-inflammatory drugs, NSAIDs, which markedly worsen HF. Avoid the use of diltiazem and verapamil in patients with systolic dysfunction because they may increase mortality and have negative inotropic effects. First-line ACEI, used to decrease afterload. Shown to increase survival, improve symptoms, and overall exercise capacity in patients in all NYHA classifications. Benefit greatest for patients with systolic dysfunction and post-ME. Number needed to treat, NNT, 25 per year for mortality. All ACEs considered equally effective. Initiate at low doses and titrate as tolerated to target doses. Angiotensin receptor blockers, ARBs, are indicated for those who are intolerant to ACEs. Do not use combination of ACEI and ARB. Beta blockers, used in systolic or diastolic HF. Note: initiate in hemodynamically stable / compensated patients at low dose and titrate upward slowly. NNT equals 25 year for mortality. Mortality decreased in systolic HF, evidence for titration to heart rate, HR, rather than specific dose. Carvedilol, 3.125 mg per bid to a target of 25 mg per bid. Metoprolol succinate extended release, 12.5 mg/day po to a target of 200 mg/day po, or bisoprolol, 1.25 to 10.00 mg once daily, currently not FDA approved for the treatment of HF. Sacubitril/valsartan, Entresto, is an angiotensin receptor blocker and neprilysin inhibitor, ARNI, shown to reduce the risk of CV death and HF. Hospitalizations in patients with HFrEF. In patients with HFrEF and NYHA class 2 and 3 symptoms who tolerate an ACEI or ARB, and CRCL greater than 30, replacement by an ARNI is recommended to further reduce morbidity and mortality. NNT to prevent 1 CV death over 3.5 years, 31. ACEs should be discontinued at least 36 hours prior to starting ARNIs. The most common adverse effects include hypotension, angioedema, and renal insufficiency. Cost is $500/month. Diuretics are helpful to manage volume overload / reduce preload. Furosemide, Lasix 20 to 320 mg/day 4/im/po divided dose. Bumetanide, Bumex 0.5 mg to 10.0 mg/day 4/po divided dose. Torsemide, Dmadex 10 to 200 mg/day po. Divided dose. Metolazone, Zeroxylin 2.5 to 20.0 mg/day PO divided dose. Hydrochlorothiazide, 12.5 to 100.0 mg/day PO divided dose. Chlorothiazide, diuryl 250 to 2000 mg/day 4/PO divided dose. Spironolactone, eplerenone, improve mortality when added to standard therapy in NYHA class 2 to 4 plus F35%. Spironolactone 12.5 to 25.0 mg/day PO, maximum 50 mg/day PO. Eplerenone 25 to 50 mg/day. Caution regarding hyperkalemia and chronic kidney disease, CKD. Digoxin reduces symptoms but has not clearly shown any positive effect on mortality. In patients with preserved renal function, CRCL greater than 50 ml/min. The recommended dose is 0.125 mg/day. Levels lower than used for atrial fibrillation are effective and safer. The combination of hydralazine, 75 mg/day divided BID or TID, and isosorbide dinitrate, 40 mg QID, is effective for improving survival and reducing hospitalizations in African Americans and can be used if the patient is unable to take an ACEI or an ARB. Ivabradine, Corlaner, can be considered in patients with NYHA2 and 3HF, F less than or equal to 35%, on maximally tolerated beta blockers with HRS greater than 70 to reduce hospitalization from worsening HF. 1b. Ivabradine is contraindicated in ADHF, hypotension, 90/50 mm Hg, severe hepatic impairment, pacemaker dependence, bradyarrhythmias, or strong CYP3A4 inhibitors. It should not be administered to patients who are currently in atrial fibrillation and should be discontinued if atrial fibrillation develops. Intravenous iron replacement might improve functional status and quality of life in patients with NYHA2 and 3HF and iron deficiency. Ferritin 100 ng/ml or 100 to 300 ng/ml if transferrin saturation 20%. In diastolic HF, no medical therapy has improved survival. ARBs and spironolactone can be used to potentially reduce hospitalizations. 1a. Additional therapies. Device therapy including implantable cardioverter defibrillators, ICDs, and cardiac resynchronization therapy, CRT, shown to improve outcomes. CRT is recommended for patients in sinus rhythm with a QRS width greater than or equal to 150 ms due to left bundle branch block, LBBB, and LVEF less than or equal to 35% and persistent mild to moderate HF, NYHA2 and 3. Despite optimal medical therapy. CRT may be considered for ambulatory NYHA class 4 patients in sinus rhythm with a QRS width greater than or equal to 150 ms, LBBB, and LVEF less than or equal to 35%. CRT may be considered for patients with LVEF less than or equal to 35%, sinus rhythm, QRS width greater than or equal to 150 ms, non-LBBB pattern, and NYHA3 or ambulatory NYHA4 symptoms. CRT may also be considered for patients with a QRS width between 120 and 150 milliseconds, LBBB, LVEF less than or equal to 35%, and persistent mild to severe HF, NYHA2 to 4, despite optimal medical therapy. ICDs are recommended for primary prevention in patients with known ischemic CM and ischemic CM who are at least 40 days post-ME, LVEF less than or equal to 35%, NYHA class 2 or 3HF, or LVEF less than or equal to 30%, NYHA IHF, and on optimal medical therapy and greater than 1 year estimated survival, generally not indicated in American Heart Association, AHA, Stage D, End Stage. HF-CRT is recommended in patients with reduced LVEF and chronic RV pacing or with bradyarrhythmias and an anticipated need for a pacemaker. Implantable hemodynamic monitoring with devices such as the pulmonary artery pressure sensor to reduce the risk of admission after an HF-related admission in the last 12 months in patients with an elevated BNP or NT-proBNP and NYHA functional class 3. In patients with HFrEF and secondary moderate to severe mitral regurgitation, MR, transcatheter edge-to-edge mitral leaflet repair device, MitraClip, may be used to reduce MR by improving the cooptation of the anterior and posterior mitral leaflets. The optimum patient selection has not been fully defined. Surgery/other procedures. Heart valve surgery. If defective heart valve is responsible, mitral valve repair especially helpful if mitral regurgitation is the primary issue and not functional. Advanced therapies such as cardiac transplantation and LV assist device, LVAD, implantation can be considered in patients with HF refractory to conventional medical/device therapies without other disqualifying medical and psychosocial conditions. Cardiac transplantation is generally considered for patients less than or equal to 70 years old with a predicted 1-year survival worse than that afforded by transplantation. Consideration can be made for patients greater than 70 years with few comorbid conditions. Indications for LVAD implantation are generally similar to cardiac transplantation but are evolving. Admission, inpatient, and nursing considerations. See heart failure, acutely decompensated. Admit patients with hemodynamic/respiratory compromise, hypoxia/hypoxemia, change in mental status, acute renal insufficiency, significant volume overload, and significant electrolyte abnormalities, e.g., hyponatremia. Discharge criteria: subjective improvement, euvolemia on clinical assessment, resting HR 100 bpm, systolic BP greater than 80 mmHg, HF outpatient education performed. Ongoing care follow-up recommendations. Critical patient education performed at all outpatient and inpatient physician visits. Rapid office follow-up, 7 days. After hospitalization. Patient monitoring. Home health monitoring by specially trained nurses have been shown to decrease frequency of hospitalizations. Readmissions remain problematic. Diet. Reduce sodium load, 1.5 to 2.0 g/day. Optimal level is unknown. Patient education. AHA, www.americanheart.org. Prognosis after diagnosis: 1-year survival 75%, 5-year survival 50%, and 10-year survival 25%. Complications: sudden death, arrhythmic, acute pulmonary edema, death, progressive pump failure.